Hi, and welcome to the Future of Dermatology podcast. I'm your host, Dr. Farah Kamangar, board certified dermatologist. We are here to talk about anything and everything dermatology related. You'll hear from me and my guests who are dermatologists, physicians, experts, scientists, residents, and medical students in the field of dermatology. We publish weekly, so if you like what you hear, hit that subscribe button and show us some love, and thank you for joining us. Hi, we're so excited to be back today with Dr. Nahid Vidal. I'm so excited. I've known Nahid for a very long time, and she is just a fantastic dermatologist and doing very, very cool things with AI around Mohs surgery, derm surgery. So I'm so happy to have her here. Dr. Vidal is the Associate Professor of Dermatology and the Chair of the Division of Dermatologic Surgery at Mayo Clinic. But also, in addition to all of that, which is already, I'm sure, lots of work, she has a lot to do with a digital health program you guys are starting, and a lot with AI around digital slides, pathology slides. You can probably explain it much better than I can. So thank you so much for being here, and would love to just hear all the exciting, innovative things you're doing.
Absolutely. Well, first of all, thank you so much for having me here. Our department is doing some incredible things. It's not just me. There's a number of us working in the digital health and AI program in dermatology. And right now we've kind of broken it up into pillars. And so I am the lead for the cutaneous oncology and dermatologic surgery pillar. So kind of all innovation within that umbrella. And then I have my colleagues, Dr. Deemer, who leads the skin imaging pillar. He's been incredible in helping us acquire devices and figuring out how we can use them from a clinical standpoint, and also further research different scenarios where they could be useful to patients. And then we also do telehealth and digital pathology as well. And so kind of where my focus has been in the last few years has been trying to go as digital as possible, because once we have everything digitized, it really allows us to build models. I'll talk about kind of the first model that we built that was more of a pilot study, kind of low-hanging fruit, which has been replicated by a number of other dermatologists and non-dermatologist AI scientists, and that's being able to diagnose tumor, basal cell carcinoma in particular, at the whole slide level. So they take the slides that we're used to seeing, typically permanent sections, but some studies have also done frozen sections. They get digitized using a scanner, and then once they're digitized, we use neural networks to basically train the model to learn what's tumor and what's not tumor. And that was done successfully in permanent sections. It was also done successfully in frozen sections with pretty good accuracy, somewhere between 80 to high 90s in percentage. And from there, what we wanted to add to that is, well, that's great. Study settings are always unique because they're typically done to kind of demonstrate how well something can perform, but there's no context to clinical flow or patient context, or where it would fit in with how we actually operate as dermatologists and Mohs surgeons. It doesn't take into account the time it may take to provide that digital process, the additional time, resources, or cost. And so one of the studies that we did is looking at whether our frozen section biopsies that we do on some patients during Mohs surgery can be used to train a model to diagnose basal cell off of very poor quality tissue sections. And so with biopsies, these are small samples. They're typically slightly fragmented, and they're frozen section biopsies, so they might have artifact in them. And kind of the pre-existing hypothesis was that you really couldn't train a decent model on that. And what we found is you can perform pretty well, high 80s in performance. And the way that we did that is we just used small number of slides overall relative to other studies. It was in the hundreds, not the thousands. And we just didn't cherry pick. So we just arbitrarily grabbed different frozen section tissue biopsies and annotated them. So that's kind of where the physician expert and time came in. It was supervised learning, and then found that it actually worked pretty well. That was kind of our baby project. And then from there, we're looking at, okay, well, what problems do we want to solve in dermatology or dermatologic surgery, and then go from there, from building. Now that we know we can do computer vision building, how are we actually going to solve problems? Most surgeons that I know don't have a whole lot of trouble diagnosing basal cell carcinoma on frozen section slides. And we have typically processes that can allow us to move forward with surgery same day without having to have a model help us? And so where are all those questions? I think where we mostly have kind of some remaining gaps in the way that we practice dermatologic surgery and dermatology is biopsies, as well as cutaneous squamous cell carcinoma, and being able to predict which of these patients really need Mohs surgery, which of them, once they have Mohs surgery, are actually going to progress to either recurrence or metastasis. We use staging criteria like a lot of other oncologic specialties, but for squamous cell carcinoma, I don't think that it's as generalizable. We've definitely all seen those patients who have had the early stage squamous cell carcinoma that then does end up metastasizing or recur. And then we've also seen those late stage tumors that we worry about so much that do quite well over time. And even though now we have accessory gene testing that we could do for a day-to-day type of thing, where can we use AI to help us? And so one component of that is helping us identify high-risk features during Mohs surgery in real time. So that's one area that we're working on, finding perineural invasion, and being able to then train the model to predict whether that patient will do well or not based on high-risk features seen on that intraoperative Mohs tissue. And the advantage we have in Mohs surgery is a lot of the high-risk features that you're going to observe is going to be caught during Mohs surgery. The biopsies are typically small samples, and for excision specimens, they're going to be often in low-risk sites that tend to do well anyway, and they might exclude certain anatomy, fascia, muscle, parotid, other glands. And so those models are not necessarily generalizable when they've been trained on permanent sections. So that's kind of where we're going in the frozen pathology-driven AI world as just one of the projects.
That's fascinating. It's amazing to get to the point where the models are working. And you're right, really the next step is where is it applicable? Where will it solve a problem? But just to get to the point where the machine can learn and really know between, like with that high accuracy and precision, basal cell between not basal cell. And is it at this point able to tell things like perineural invasion? Do you feel like you've had high level of success even just teaching it that level of detail?
Yes. I don't think we've been able to identify it through unsupervised learning. So it's not just kind of finding it on its own. So it does take an expert to kind of go through and annotate, but the annotations aren't even highly specific. I think if you annotate just a few, it's enough to start to be able to identify that pattern. There are some areas where the models get confused. And so if it's never seen a certain type of anatomy before, it might flag that as tumor or something high risk.
Gotcha,
And we saw that when we tried to transfer squamous cell carcinoma from that was learned on a permanent sections to frozen, we saw that it would confuse hair follicles or parotid or muscle, fascia, just deeper tissue in general. Inflammation can also be hard. So things like inflammation that are hard, even as trained Mohs surgeons, are still going to be kind of difficult for the model. But I think we haven't found, and there's no study yet to have shown how many whole site images you have to use to kind of get to that point where you can have that reliable accuracy. But we're definitely getting to a place where being able to do that, identifying those high risk features for us, is very much possible. And so not diagnosing for incredible. Us, but providing more of an assistive role in our jobs.
Yeah, absolutely. No, it's so incredible where the technology is going. I think, was it last year, a few months ago even, I think it's just stuck a picture of a DermPath slide just into GPT. So not as sophisticated as what you guys are doing. And it did pick up, this is a skin biopsy. I think it was like a basal cell. It was like likely a tumor, but didn't go past that to what you guys are doing with all the learning. So it's incredible then that you can just, like, the technology's there, and then you can add on to it all these layers of just intricacy. And I'm curious, is the setup that you have the physicians, and do you have a group of engineers at Mayo Clinic that are also sort of like from the engineering side working on it, or what's the sort of the setup of the innovation center, the way you're doing it?
Yeah, so it's growing. I think we're very early kind of in our program right now, but amazing things have already happened. We do have an AI scientist as well as a data scientist. And then depending on the project, we can outsource additional engineers that are needed. For the generative AI project that I'm working on, it's a much broader team that goes beyond dermatology. And that was based on an institutional grant that then was able to get us very specific roles that we know we needed to build what we're trying to build. And so, I think that there will never be enough AI scientists to be able to move things as quickly as the industry. But at least the intentions that we have are to either find solutions, real life solutions that help us in practice, or to find real life solutions for things that plague our patients. And so I think kind of an advantage that we have in an academic center is we have a better understanding of the clinical gaps, the patient needs, and also just the incentive to want to improve what we struggle with as academicians and physicians. So, but it moves slower. It's a slower pace.
Though definitely, but definitely just that's where it starts in the academic centers, because like you say, it really needs to go a few steps further to solve the problem to get into everybody's hands, but it has to start really somewhere with resources. So it's incredible that your center has that. And then are you then kind of building, is the program to build like fellows around it, students to come in? Like what's the setup? Let's say someone's listening and they're like, I want to do this. Would this be like a good place for someone to do residency if they're hearing this and going, oh my gosh, this is the best thing ever, and I want to do this type of research?
Absolutely. I think we do attract medical students and residents who are innovation focused. Yeah. I don't think that's a coincidence. So we do have several residents and medical students who have contributed greatly to our projects and have a lot of interest. Mostly just self-learning. So, I do have kind of a resource page of things that I use to kind of self-learn and become literate in AI. And I think that anybody without even the background in computer science can get there. Maybe not necessarily doing complex builds yourself, but at least being able to speak the language with the team that does that. That's really important. Sometimes things get lost between the scientist groups and the physician groups who all kind of have the same vision but don't quite speak the same language, or maybe there's like different areas of expertise. We're having to translate what we're trying to do in medicine to a language that can be understood. So we do attract people definitely to our programs, but then separately from that, just like with anybody who's doing research, you apply for grants. It's a lot of work. It's a lot of grant writing. You get the grant, hopefully, and then in my case, I was able to fund an AI and innovation research fellow full-time. So we have the wonderful Dr. Jorge Rios, who works with me, and he's going to be with us for about 2 years. And so he's already done amazing stuff in his first 6 months. And so kind of the advantage to being a fellow with us is that you get to be really at the edge of all the amazing innovation happening that's unpublished. You're watching it through all the mistakes and the lessons learned, and kind of from the ground up building of all these cool tools. So that's kind of how that happens. It's very similar to anybody else's research project, where you get the idea, really hone the idea, apply for some grant funds, and then be able to recruit the help that you need to execute.
That's fantastic. What a lucky opportunity, actually, to get to be the fellow working with you just at the advent of all of this technology. And you're 100% right about the communication piece. We've talked about that in other podcast episodes before too, about how we literally just need to translate between physicians and tech engineers. And sometimes they don't know what we're trying to do. And a lot of technology is being built around what they think we would want. So it's so amazing now that the doctors are all kind of at the forefront as well. So the solutions are problem-based rather than just random technology that's been handed out to us over the years. So that's fantastic too. And what is sort of going on, if any, this might be in the other pillar, but around the skin imaging, any thoughts there? And that's always a hot topic at most of the meetings now. And it's kind of interesting that I think that we're asking the AI models to like diagnose melanoma, which is really hard, even for a dermatologist to do. That's why we have the biopsy and derm path assistance with most of it. So I would say, admittedly, we're giving it like one of our hardest tasks and be like, can it do it well? Yes. But are you noticing are you guys taking technologies, bringing it and sort of testing it out? Are there any technologies that are standing out as being a bit more effective or more use cases that we should be thinking about?
Yeah, you mentioned so many great things about just the impact that skin imaging devices have had. I think that and things have evolved. I think in the beginning, several years ago, it wasn't problem-based. I think that it was solution first and then try to kind of work backwards from there. And I think they were unsuccessful. They weren't serving the needs of the patients or serving the needs of dermatologists or even primary care. And everybody, I think, was just honed in on melanoma, that there are also potentially missed opportunities for the things that we spend a lot of time doing. A lot of the biopsies that I do are not melanoma. They're precancers, or that you're suspicious of being full skin cancers, or they're squamous cell carcinomas that you're sure are invasive, and you're just trying to prove it. And so I think that where we're finding some utility and what we're investigating right now is several different skin imaging devices. And so we have the WB360, which images all of the patient's skin over a very short amount of time, taking tons of pictures, and then being able to analyze differences over time. So I think that's a few academic centers have already acquired that device, and I'm sure there's going to be an explosion of things that we learn from that tool, and that is led by my colleague, Dr. Deemer. And then what we're also kind of working in concert together with is microscopy. So that's going to be kind of our main focus coming up here over the next year or so. We plan to just really look into where microscopy can most useful for us. And microscopy has been around a long time, but the images that it has produced has been more along the lines of an ultrasound-like image that requires time, expertise, steep learning curve to really become proficient in interpreting it. And it takes time and resources to even acquire those devices. And so it hasn't really caught fire, but now that we have NI enablement, several types of microscopy, whether it's reflective confocal, optical, or even open top sheet 3D microscopes, now have the ability to use digital staining, which is basically taking tissue, putting it kind of against a camera, using imaging lasers to then take the tissue and either create a 3D model of that tissue, or in the case of Mohs surgery, just show us what we need to see, which is the edges, the deep base, the peripheral base, and then use digital staining to recreate an image that looks exactly like H&E. And so we see there's been a few publications already on just demonstrating how much like regular gold standard H&E you can get to with AI. And that I think is going to be where things are going to explode. Because if we can save patients from having to get biopsied, we can maybe then figure out, well, first of all, we can do bedside kind of pseudo biopsies where we're using kind of digital planning. I also see it having a great role in Mohs surgery, where for the more complex cases where we're doing a number of scouting biopsies, the ability to just be able to do that digitally without a single poke and then create our operative plan, maybe we'll do a better job in Mohs surgery. So that's kind of some areas for that. And then also just real-time decision-making, at the bedside, how many times have we as dermatologists come across that borderline lesion? Is it AK-SCCIS, or is it SCCIS, or is it invasive? And we've got some great dermatology examination skills. We've got dermoscopy, but it would be incredible to be able to just delineate depth. And so the only information we get from from handheld microscopy is determining whether it's invasive or not. That alone, I think, provides us with some decision-making capabilities to decide, okay, can I do this with topical, or does this need to be excised? And then once we perform an actual biopsy, imagine if we can use microscopy to look at the edges right then and there and decide whether or not we got it, or whether or not it actually needs to go to Mohs surgery. And so I think we'll probably have some refinement and major paradigm shifts in dermatology because of microscopy-driven research. But my hopes are that there's a diverse enough data set that we test it on, so that we don't just try to generalize a tool that works in cases where we don't really need the assistance to begin with. I think we got to do tough things with microscopy to figure out its limitations and figure out where it's best used.
Yeah, no, that's incredible to think about how like dermatology, the way it's taught and practiced in 5 to 10 years, how much that might change. And as you're saying, I'm kind of thinking about all the areas that are really routine to us, but when you really dig deeper, we're sort of just guessing sometimes. And we have our guidelines of, if we're doing excision, do your 3 millimeters, or if it's melanocytic, it'd be 5 millimeters, 1 centimeter. But there definitely those are guidelines based on the statistical analyses. And sometimes you might look at a pigmented lesion, maybe even take out a Woods lamp, like how tech 1.0 is that, right? Like just a straight Woods lamp to try to help you find where there might be some surrounding pigmentation. When you think about it, actually, we really, even though sometimes there's a fear for technology, we sort of just need to do it, right? We need this technology assistance, because otherwise we're still sort of very much doing dermatology the way it was done
many, many years ago. So it's actually really exciting that a lot of this is already starting and taking place. And then, like you said, that some of the devices are getting smaller too, right? To the point where you can actually bring the microscopy device into your clinic as opposed to the older machines. So it's all actually incredible. And I wonder what derm path training is going to look like in dermatology residency in like 5 years, or if we even need frozen sections anymore, because you can just the technology can turn everything into H&E. It's really cool.
Yeah.
It's just really cool to think
Yeah.
about all the possibilities.
Yeah, I think remaining flexible is important, but as long as we're patient driven
Yeah.
and like you said, as a specialty, just we kind of have to get with the times. Technology's
Yes.
here. I think as long as we have a say in it, hopefully it helps us with all the things that we struggle with. And the things
Yeah.
that even if we were, if we were the patient, if someone said, hey, instead of doing a biopsy right in the middle of your face, we could use this microscopy
Yeah.
to decide whether we need to or not. Wow, I mean that's a complete game changer for a lot of patients, and so definitely some excitement around it. I don't have a whole lot of fears with it. I think mostly there's going to be some growing pains with flow and
Right.
efficiency, and just trying to make sure it doesn't um, add to the access gaps that we might have already,
Yeah.
where in rural areas, if they're still doing kind of traditional dermatology, and the high tech centers, have all these cool things available to people. Like I can see a world where there's a wider gap, and I can also see a world where
Yeah.
that digitization actually allows access, improved access. And so hopefully we kind of just go in the direction of thinking about greater good and easier access for all. And I believe that
Totally.
dermatologists and Mohs surgeons will still have a role. But you're right. I think that
Yes.
frozen sections and how it changes and how the role of a histotechnician changes, I think everything's gonna evolve quite a bit. Dermatopathologists, all that. Um, but yeah,
Yeah.
it's exciting to think about how things will change.
Super excited. And I agree. I think if done right, it'll just improve health equity, and especially with the telehealth pieces rather than the other way where it creates more of a divide. So fun to just hear about everything that's going on. And then lastly, we always ask, since it's the Future of Dermatology podcast, although we've been, I think, talking about a lot of the future, but what are you most excited about, or what do you see as the next changes in the future of dermatology?
What am I most excited about? You know, even though my focus is Mohs surgery and frozen sections, I think what I'm most excited about is actually the stuff that transcends our specialty. It's there was a great article recently. I'm going to give a shout out to one of my mentees, Fatima Mirza, who has a partnership with OpenAI, as in the sense that they found a use for using large language models to help people find their voice. And so the example was somebody who um, could no longer use the voice that they were born with, but that natural voice can be kind of created de novo through generative AI from OpenAI. And so I think that's an interesting use case of a non-healthcare app, but using kind of the technology that's already existed for somebody with a medical limitation. And I thought that was absolutely brilliant. So I wanted to give her a shout out for just that genius idea. So what I'm most excited about is how can we help people beyond dermatology, and also how can we help all physicians? I think nobody goes to medical school to chart for a million hours or to spend all of their time doing a lot of curation. How much of our time is spent kind of organizing, and how many of our staff members are serving that function for us, summarizing. So much of residency was learning how to summarize in a way that your attending liked. That was like the trick
So
is
true.
figure out how to summarize all the information that matters in about 90 seconds in a way that is effectively communicating. And we all have limitations as humans. And so if we could have technology that does it for us in an automated way, reliably and well, and in a standard way that has nothing to do with personalities or kind of our biases, that would be amazing to transcend all of that and make our lives easier. And so if I could identify one biggest excitement, it's to allow us to just practice medicine and kind of have more of that feeling of the old charting days where you're doing what absolutely you need to do to use your medical degree, but everything else is hopefully stuff that is easier.
Oh my gosh, absolutely. It's sort of like we were practicing a certain way, then early technology came, impeded it, but then maybe now it's like coming full circle. We're going to go newer technology, and then just get back to what we were doing. Just go see a patient.
That's right.
Right. You need to, write your orders and then go home. Like have fun.
Yeah. If someone told me,
and then go home
you
and
just have to come to work
writing
and see your patients and do surgeries, and then you go home.
That's
wow.
it.
I mean,
that's how it used to be. We've never seen
Yeah.
that, but that
No.
I've heard stories of.
I've heard stories. The golden days. Yeah. I hope we get back to that. Yeah. Yeah. I think that was always the vision, right? It's like what a big miss for medicine in general is all this technology came out to like help us, but we kind of became servants to the tech. And I'd love to see that reversal, have it work for us.
Miss. We feel it, our patients feel it. And hopefully hopefully now it's like the time where the physicians are in the rooms, are the first people kind of building these solutions, like you, which you're the physician, building these solutions. So it gives us a lot of hope, and it's so exciting to see.
Super exciting.
So thank you so much, Nate. Thank you for joining us.
Thank you. Good to see you again too.
You too.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.